So Sara Crager has got some really important thoughts about sick patients with COVIDs and who you should tube and when and how you should manage them. And she put this together just at her own home after a night shift, sort of for internal use, but she sent it to me to take a look at, and I'm like, Sara, I've got to send this out. People have got to get this information. She really goes through beautifully how to think about this. Now, there's a lot of supposition in here, of course, because we don't exactly know, but I think you'll find it extraordinarily helpful. And then once we get a chance, after this huge surge goes away, we'll get Sara into the studio and do it in the old-fashioned, beautiful way that we shoot these. But for now, here's Sara Crager. It's about an hour long, but it'll be the best hour you've ever spent if you look after sick COVID patients, I can guarantee you.
Hey everybody, this is Sara Crager, and today we are going to talk about another physiology to practice, and this one is going to be COVID intubation triggers. Sorry it's been a minute since we've put something up online, but it's been COVID central here, and so I've been spending quite a bit of time in the ICU, which means quite a bit less time in the studio. The upside, if we want to call it that, is that I've got a lot of time that I've got to spend thinking about a question that I suspect all of you have also been spending quite a bit of time thinking about, which is the question of when to pull the trigger on intubating COVID patients. And this is something that I am struggling quite a bit with, and probably struggling even more with because it seems like this is probably relevant. There have been a couple of these sort of clinical practice guidelines or reviews about severe COVID, critically ill patients with COVID. And all of them say something along the lines of this: deciding when a patient with severe COVID should receive endotracheal intubation is an essential component of care. I'm pretty sure that's obvious to all of us. And in fact, it's become so obvious, it's even made it into review articles in the likes of the New England Journal. And yet again, I find I say this many times when I'm talking about COVID, I wish that I could tell you the answer. And I am, again, finding myself having to tell you that, in fact, I am not quite sure I know the answer to this. That's the bad news. The good news is that I've spent quite a bit of time taking care of quite a few COVID patients in the recent past. And I'm thinking, but maybe just hoping, that I'm getting a better sense. I'm getting a little bit more comfortable with my clinical sense of how to make that decision. And I'm getting a little bit more comfortable making that decision. And the decision to intubate, what they're basing this on, what we're all basing this on, is not rocket science, right? I think there's really two things that we're looking at when we're thinking about this decision to intubate. And the first is, what's the O2 sat? How hypoxemic is my patient? And that's normally mostly what we're basing the decision on, or at least it was until COVID hit us. But then the second piece of this is the work of breathing piece. And increasingly, this is becoming what I am basing these decisions on. I wouldn't say exclusively, but far more than hypoxemia. So let's discuss. We're really going to talk about three things. First, before we figure out how we're getting there, we have to remember where we're going. So we're going to just briefly revisit what exactly are we trying to do when we're intubating somebody? What's the goal here? Two, the intubations, whens and whys. How do we make that decision regarding hypoxia? And then intubation, whens and whys. How do we make that decision in the context of work of breathing? So first, what is our goal of intubation? Well, I think this really, really depends. And it depends on whether we think we're having an airway problem or a lung problem. Why? Because if I'm having an airway problem, intubating the patient fixes my problem. It's not just a Band-Aid. It's not just a temporizing solution. Problem solved. Airway controlled, done. So I often have a pretty low threshold to intubate patients that I think have an impending airway problem. Because if that's the case, I've definitively solved their problem by intubating them, call it a day, go home, all good. The problem becomes when I'm intubating my patients for a lung problem. And this is what we're doing with COVID, right? Because we all have to remember that if we're intubating our patients for a lung problem, we have not definitively solved that problem by intubating them. All we have done is put them on mechanical ventilation. And what is the goal of mechanical ventilation, really? Well, unfortunately, mechanical ventilation is not actually solving your lung problem in any meaningful way. What are you actually doing with mechanical ventilation? Well, the primary thing you're often doing is you're just buying time, right? You're not saying that, by putting you on a ventilator, I will have fixed the problem with your lungs. Because that's just not true. That's not what you're doing. What you're really doing here is you're just buying time for the lungs to heal. You're saying that, okay, you know what? Your lungs not doing so hot. And your lungs can really only get us up to a saturation of, 60% right now. That's not compatible with life. So we got to intubate you to buy some time where we can make, your oxygen saturation compatible with life while we're waiting for the lungs to heal. And that's really the primary goal normally when we're intubating patients. We're just buying them time and trying to prevent doing damage to the lungs with our ventilator while we're waiting for them to heal. Now, there's actually a second goal here. And this goal has become much more relevant with COVID. And the second goal of intubating a patient is not just buying time for the lungs to heal, but the second goal of intubating a patient is to prevent self-inflicted lung injury. Now, I have to say, this was not something I thought a whole lot about until COVID hit. But this is something that I've been thinking a lot more about recently. And so it's something we're going to talk about quite a bit. But first, let's get to the simple part, or at least what recently has becoming clear to me is actually the simple part here, which is when we talk about hypoxia. And when and why do we intubate based on their oxygen saturation? So oxygen saturation, that makes all of us very nervous, right? Any EM boards questions that starts off with the patient shows up to the ED and their saturation is 65 should end immediately with you intubating the patient, right? On the EM boards, and frankly on the critical care boards, that is not rocket science. And why is that? Well, it's goal number one. If a patient is so hypoxic that their degree of hypoxia is no longer compatible with life, you intubate them so that you can buy time for those lungs to heal. You support them with a ventilator while you're fixing whatever the problem was that caused their sat to be there in the first place. Now, problem is that what I would like to do and what I've wanted to do throughout this entire pandemic is to say, okay, that's a logic we're used to dealing with. We're used to dealing with the idea that if you're hypoxic, then we should intubate you. And what I would love to do is give you a magic number. Give you a number and say, you know what, when the O2 sat hits 75, 80, 85, some people are saying 92 is the magic number, that is when you intubate your patients. We like numbers. Numbers are nice. They make it really easy for us. They make us feel confident and secure in our decisions. It allows us to give our nurses numbers to say, when the number reaches this, call me and I shall intubate the patient at the end. Unfortunately, I have yet to figure out what this magic number is, and I don't think it exists. And I think the first reason why this doesn't exist is that we all have to accept once and for all that making a number pretty simply does not make the patient better. Now, sometimes it does, but sometimes it doesn't. Those two things are not automatically equivalent. And we are seeing this with COVID and, forget COVID, even long before that, we have been seeing this with the lungs over and over and over again. So once upon a time, quite a while ago, around, 1975, turned out that we used really high tidal volumes, greater than 10 cc's per kilo. Why was that? Well, it was because studies have shown that it made numbers better. Studies had shown that if you used really high tidal volumes, it made your O2 sat better, it increased your lung capacity numbers, all of your numbers look better. Unfortunately, nobody lived happily ever after because it turned out that even though doing such things made the numbers better, it actually probably killed patients, which is not the goal. And so over and over again, in medicine, in critical care, in just the lungs, making the numbers pretty does not make the patients better, necessarily. Sometimes it does, sometimes it doesn't. You really sort of have to differentiate your goal, which is making the patient better, from your target, which is X, Y, and Z number you think will help you make the patient better. But don't conflate those two things. They're not the same. Now, with hypoxemia, I imagine you're all thinking, okay, that's nice. I hear that. Philosophically, I understand that making the number pretty doesn't necessarily make the patient better. And that's cool, but no, seriously, how low is too low? Yeah, number and all, but really, how low is too low? And this question has become really, really complicated for me. Partially because of this sort of what we're calling happy hypoxic thing, where the patient is just not matching the number, but also because I think of a lot of these mixed messages that we're all getting, that I've been getting, from sort of everybody in charge of putting out recommendations that we're all supposed to be following in COVID land. And really, a lot of the recommendations come down to something along the lines of this. On the one hand, don't intubate too early. We made that mistake early in the pandemic. It was a bad idea. Don't do that. On the other hand, if you read a lot of the guidelines, a lot of the official do this because we said so, it'll tell you to keep the O2 sat greater than 90. And that sounds nice. But in reality, balancing these two things is not often quite so simple. So we end up with guidelines that look something like this. Many of the hospital algorithms, guidelines, if you look at some of the official recommendations, up to date, what have you, you see something that looks like this. You see a flowchart with nice arrows that tells you that you should be titrating the FiO2 to target an O2 sat of 92, in this case, 0.96% for the majority of patients. Now, I know that many of you who are working at hospitals like I am right now are already laughing at this because that sounds like wishful thinking. But okay, let's just run with it. So we apparently should be titrating the FiO2 to a target oxygen saturation of 92. And then we're supposed to say that unless we can keep their oxygen saturation at about 92% without having to have an FiO2 of greater than 60%, then we should probably do something about it. In fact, if we end up with a patient who's satting less than 92% on an FiO2 of greater than 60%, well, no matter what the work of breathing is, this algorithm is telling me to intubate this patient. So yeah, I think that sounds great on paper. I think that maybe at the places that are coming out with such official recommendations, maybe that works in those places. But what I will tell you is that, at one of the hospitals I'm at, that is completely laughable. Because if we were going to do that, we would simply intubate our entire PCU. We'd probably, our step-down unit, we'd probably be intubating most of our floor patients, and we would literally, from today to tomorrow, go from having, I'm losing track, dozens and dozens and dozens of intubated patients to over 100 intubated patients overnight if we were to say everybody's O2 sat should be above 92 on 60%. Because right now, my entire step-down unit there is full of patients whose sats are in the mid-80s on 100% high-flow nasal cannula, and many of them are also getting 15 liters face mask over that. And so because of this, I've gotten pretty comfortable not intubating those patients. Now, would I like it if all of my patients had a SAT of 92 or better on an FiO2 of 60% or less? That would be fantastic. But unfortunately, in medicine, as in COVID, as in life, turns out that you cannot have everything you want all at the same time. But it's really set up a struggle for me. This, yes, hypothetically, I want their SAT to be better. I am worried that their O2 requirements are so high, but I know I can't have everything I want at the same time. And it's become really complicated, especially because COVID has turned into this situation where there is this huge mismatch between what my patient looks like and what the numbers look like. And, This mismatch between what the patient looks like and what their numbers look like, this is not totally a new thing. This is not something we've never seen before. And actually, I think this is why early on we kept doing this is COVID HAPE thing, is COVID HAPE thing. Is this a high altitude thing? Why? Well, because this was the only time we've seen this. And I think that we've pretty well established that COVID and HAPE are not the same. That being said, I think there's some sort of interesting thought experiments to be done here. So I don't tend to climb a lot of mountains because I'm not super athletic. I fall down frequently. It's a bad idea for me to do it. But fortunately, a good friend of mine likes to do such things and sent me some pictures when he was on a mountain, very, 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 one of the really tall ones, and sent me a picture of the following. His oxygen saturation was 77%. So let's say I'm looking at this stat and I'm like, 77%. It is definitely less than 92%. That is bad. I best let this patient know that I have to intubate them now because their stat is 77%. So I go and I find my patient and there they are. And I realize that I probably can't chase them up that mountain and they don't really look like they need to be intubated. Yeah. And so clearly, in certain circumstances, we are comfortable with a disconnect. We're comfortable with the fact that this guy's SAT may be 77%, but we're not chasing him around trying to intubate him because we're comfortable with that disconnect sometimes. Now, of course, comparing that guy to a COVID patient is certainly, on some level, an apples to oranges thing. Of course it is. But at the same time, what I think it should highlight for us is that it should be a thoughtful decision of how much of that number to patient mismatch, how much of that disconnect we feel okay tolerating, and how that's a thoughtful decision, not a reflexive decision based on numbers. And how really this sort of, yes, keep the SAT better than 90 or 92 or whatever number we decide, trying to balance that with not intubating too early, it's not simply don't intubate too early, but the SAT is less than 92. I guess we have to do it. It's not that simple. In reality, really, it's more a lesser evil issue. It's more my patient is just going to be hypoxemic. They actually look pretty good. And would I like them to have a SAT better than that? Yes. Do I think I could maybe get it better than that by intubating them? Yes. But what is really the lesser evil here? And that question, unfortunately, is a little bit complicated. And I've been really struggling with it. But I think the first thing that we have to sort out, the first thing that we have to answer when we're thinking about this question is, how bad is hypoxemia? How bad is it really? And in order to think about that, we are just going to take a field trip back to pulmonary physiology for a little bit here. So let's think about these two concepts. Let's compare and contrast the concepts of hypoxemia versus tissue hypoxia. And they're not the same thing. You probably remember somewhere in med school when you had that really, really annoying attending who would get upset if you used the word hypoxemia instead of hypoxia, and that was really irritating, and they would correct you. And I found that really irritating at the time, but it turns out that that difference is actually important. Because hypoxemia means your SpO2 is low. Your oxygen saturation is low. That's what hypoxemia is telling you. You look up at the monitor, their oxygen saturation is 75. That's hypoxemia. But that is very different than tissue hypoxia. Tissue hypoxia is when your tissues, your end organs are not getting enough oxygen. And it turns out that these two things do not always coexist, that you can have hypoxemia without tissue hypoxia. You can also have tissue hypoxia without hypoxemia, but for the moment, since we're talking about COVID, we're going to talk about the case where your oxygen sat sucks. It's, 75. But actually, your tissues aren't necessarily hypoxic. So the first question here is hypoxemia itself a problem? Is hypoxemia without tissue hypoxia a problem? Is a low O2 sat, even if your tissues are getting enough oxygen, is that a bad thing? Why or why not? Well, it turns out we don't actually know. Because it turns out that even if you have some no tissue hypoxia, even if your tissues are great, just hypoxemia may be problematic. And so why might that be? Well, it turns out that just having hypoxemia will do the following. It causes something called hypoxic pulmonary vasoconstriction. And that by itself may be a problem. We're not totally sure. What's the mechanism here? Well, the idea is this. In your lungs, there's some part of the lungs that have low oxygen levels, and some parts of the lungs have high oxygen levels. Now, this is true in normal lungs, and it's even more so true in sick lungs, whether those lungs are sick from COPD or pneumonia or ARDS or from COVID. Now, if you're the lungs, what do you want to do? Well, if you're the lungs, do you want to send oxygen to the bad, sick, poorly oxygenated areas? No. You want to send the blood to the well-oxygenated areas of the lungs. How are you going to do that? Well, as I said, you're going to do it through something called hypoxic pulmonary vasoconstriction, whereby the lungs are going to vasoconstrict the pulmonary capillaries around the areas of low oxygen, thereby shunting the blood to the areas of high oxygen, which allows you to better oxygenate the blood. Now, if you have a degree of tissue of hypoxemia, right, of low blood oxygen content that causes hypoxic pulmonary vasoconstriction, whether or not that's actually causing in-organ tissue hypoxia, it could still be a problem. Because this hypoxic pulmonary vasoconstriction, it could cause some pulmonary hypertension, right? It could cause maybe some increased tendency to, small thromboses in the pulmonary capillaries. That is certainly possible. In ARDS, it's possible that maybe something like this is happening. But we don't actually have a lot of evidence for this in COVID. Interestingly, there's been some data that we are not seeing increased pulmonary artery pressures to the extent that we might expect to see in COVID. There's some hypotheses in COVID that, in fact, maybe part of the primary disease process is a loss of hypoxic pulmonary vasoconstriction. So in COVID, we don't have clear data that hypoxemia, in the absence of tissue hypoxia, is intrinsically necessarily a bad thing. So it could be, but it's not at all clear that that is the case. So, is hypoxemia in and of itself a problem in the COVID patient? I have no idea. I really don't know. Now, tissue hypoxia, is that a problem? Of course it is. That's always a problem. But when we're thinking about tissue hypoxia, we have to be a little bit sophisticated about it. So I think the first thing to understand is that you have to have pretty significant hypoxemia before your tissues actually get hypoxic. So if we go back to this guy, he was satting 77%. And he does not look like a person who is experiencing significant tissue hypoxia here, even though he's hypoxemic to 77%. And so again, yes, tissue hypoxia, intrinsically a problem, absolutely, but your O2 sat has to be pretty low before you truly start experiencing tissue hypoxia. And so a much better way to think about tissue hypoxia is not just looking at the O2 sat. You really have to think about it in a bigger picture, more thoughtful physiologic way. You have to think about it in the context of your oxygen delivery equation. Because oxygen delivery, getting oxygen to the tissues, is much more complicated than just your oxygen saturation. And in reality, it's actually a balance here. It's an oxygen supply, oxygen demand balance. And when you start getting tissue hypoxia is when that balance gets out of whack, when you get out of balance here. Now, the oxygen supply part is the part that we're usually concerned with. And usually when we think about oxygen supply, the first thing we think about is their oxygen saturation, right? Is their O2 sat okay? But it turns out that one, you don't really start getting an actual oxygen supply issue, true tissue hypoxia, until your saturation is actually pretty low. your saturation has to be like low 70s with maybe a PaO2 in maybe the low 40s before that by itself is really going to start to cause tissue hypoxia. And so your oxygen supply is not just based on it, and your O2 sat has to be pretty low before that intrinsically causes you problems. And there's a couple other really important things that determine your oxygen supply. So your cardiac output, for example, and your hemoglobin. Because, if we're going back to our guy over here who's satting 77%, but who is, climbing up this mountain, even though his oxygen saturation is not super fantastic, we feel pretty confident that his cardiac output is excellent and that his hemoglobin is probably not 4. His hemoglobin's probably pretty solid. And so I start becoming much more concerned about a patient's oxygen saturation if I think that the other variables that determine oxygen supply are not intact. And so I'm going to be much less concerned about a young, relatively healthy person tolerating a low O2 sat than I am going to be about, if I have a 92-year-old with an ejection fraction of 10 and a hemoglobin of 4, now I am quite concerned about this, and I'm a little more invested in keeping their oxygen saturation up. Now, in terms of an oxygen demand issue, this is really all about their metabolic state, right? So are they climbing a mountain or running a marathon? Or are they kind of just hanging out in bed? Now, there's some interesting issues that have come up with COVID, looking in critically ill patients, that there's some really interesting thinking and studies around, might these patients just be in a higher overall metabolic state than normal critically ill patients? Maybe, unclear. Also, keep in mind that breathing really, really heavily is sort of like running a marathon with your diaphragm to a certain extent. But overall, again, when I'm thinking about these issues in a COVID patient, my oxygen saturation is only one variable. And I realize that if that is really the main thing that I'm having a problem with, that I'm not so worried about the demand, I'm not so worried about the cardiac output, the hemoglobin, it has to be pretty low before my oxygen saturation results in true tissue hypoxia. Now, yes, tissue hypoxia, absolutely, in and of itself, no matter what else is happening, is an intrinsic problem. And so is there something we can do to actually measure when this supply-demand net equation has actually resulted in tissue hypoxia? Well, maybe, kind of. Because remember back to medical school, when you learned that what happens when you get tissue hypoxia? Well, you start to get anaerobic metabolism, which produces what? Lactate. So, I told you that your oxygen saturation is not your magic number here, but is your lactate now your new magic number for when to intubate your COVID patients? Turns out, as might have been predicted, it's not quite that simple. So here's the problem with lactate. If lactate only indicated tissue hypoxia, that would be fantastic, but it probably doesn't. So here's the deal with lactate. Let's say you have a lot of epi going around. Somebody's a little bit stressed out. We got some epi. What does epi do? Well, epi is going to activate your beta-2 receptors. This is your normal pathway. You got some epi, activate your beta-2 receptors, causes glycolysis to be upregulated. What does glycolysis do? It produces a bunch of pyruvate for you, which goes into the TCA cycle. The TCA cycle then takes that pyruvate and produces energy from aerobic metabolism. So that is how this is supposed to work. When we are having a normal aerobic day, where we are not having tissue hypoxia, we are not producing anything from anaerobic metabolism, this is how things look, right? Okay, now what happens when somebody gets a significant physiologic stress? Let's say they are running a marathon, they are having a seizure, they're having an MI, they are in shock, or for example, they have COVID, and they get a significant physiologic stress. Well, that significant physiologic stress is going to amp up their epi. That epi is going to aggressively activate those beta-2 receptors, and that is going to amp up your induction of glycolysis. Well, when you upregulate glycolysis, what's going to happen? Well, you're going to create a whole bunch more pyruvate than normal. Then you're going to feed all of that pyruvate into the TCA cycle. But at some point, your TCA cycle is going to be like, no, I'm good. I have enough pyruvate. I can't handle anymore. All good. I got some leftover. So what is going to happen to that leftover pyruvate? Well, it's going to get converted into lactate. Now notice, nothing here actually involves anaerobic metabolism. Nothing in this mechanism of lactate generation is actually resulting from tissue hypoxia, right? And this mechanism of lactate production that is independent of tissue hypoxia is called stress hyperlactemia. And increasingly, we're beginning to understand that in any condition, in shock, in any condition causing an elevated lactate, a lot of that is actually probably due to stress hyperlactemia as opposed to tissue hypoxia. And so the problem is that turns out COVID is a fairly stressful experience on the body. It is a physiologic stress, and so can probably produce stress hyperlactemia, whether or not the patient is experiencing true tissue hypoxia. And so is lactate actually a magic number to tell us when the patient's O2 set, their degree of hypoxemia, is actually resulting in tissue hypoxia? Nope. Yet again, not a magic number. And so when I am confronted with this lesser evil decision of is hypoxemia or intubation the lesser evil? Part of it is, do I really think that this patient's degree of hypoxemia by itself is a problem? Do I think that hypoxemia by itself is a problem? I don't really know in the COVID patient. We don't have clear evidence that hypoxemia in isolation is a problem in the COVID patient necessarily. There may be some of that evident in ARDS, but as much as we like to think they're identical, COVID is not necessarily just like ARDS. And do we have a full handle on how to manage the intubated COVID patient? Not necessarily. So is tissue hypoxia in a COVID patient a problem? Absolutely. Is hypoxemia without hypoxia a problem in a COVID patient? Probably, but is it a greater evil than intubating them? Where do I draw that line? And that is the thought process that I've really been struggling with a lot of these patients. But when thinking about this, if I suspect that my patient is hypoxemic but does not have tissue hypoxia, I've often been letting them run pretty low because it is not clear to me that tissue hypoxemia in isolation is necessarily, intrinsically a bigger problem than what will occur if I intubate the patient. It's a balance, but I just don't know. Now, another big piece of the COVID patient is this, and I think that this is really, really important, and this has been a big shift in thinking for me, and I think for a lot of us, and that is the question of the trajectory of their hypoxemia. Why? Well, I'm used to seeing the following happen. I am used to seeing a patient, and if they come in and they're satting 85%, so pre-COVID, if I had a patient who came in and they were satting 85% oxygen, I was pretty clear that this patient was 85% on their way to 35%. And most patients previous to this, if they're in a bunch of oxygen, they're still satting 85%, their pretty clear trajectory is they're going to need to be intubated because they're going to crump. Now, what I'm seeing with a lot of COVID patients is it's not quite like that they come in and they're satting 85% on a lot of oxygen, and they are 85% on their way to 85%. And so the trajectory has become really, really important to me because the trajectories I'm seeing with the hypoxic COVID patients are very different than the trajectories that I see with a lot of the other patients that are hypoxemic. And so that also plays into my calculation when I'm trying to weigh and balance what is the lesser evil here, hypoxemia versus intubation, and observing the COVID patient's trajectories and knowing that in many, not all, but in many, they're not necessarily at 85 on their way to 35. Their trajectory may count at little ups, little downs, but not that precipitous drop that we see in a lot of hypoxemic non-COVID patients. Okay, now let's get to probably the most complex part of this, which is talking about the whens and whys of intubation in the context of work of breathing. Because as I said at the beginning of this, work of breathing has become a much more important number to me than their O2 sat. It's become a much more important assessment to me when I'm deciding to intubate these patients. But I've also learned that in order to use their work of breathing as an important piece of the puzzle in making this decision, I have to be a little bit more sophisticated, a little bit more nuanced about what work of breathing actually means. So what does work of breathing actually mean? Well, I think that, if you asked most medical students, the first thing they would say is, well, how fast are they breathing? And that's reasonable. That's not wrong exactly. But I think that we really have to make a distinction here between the patient's respiratory rate and their accessory muscle use. Because respiratory rate is super simple. It's super straightforward. We like it because it's a number. We can measure it, we can trend it, we can write it down, we can make cutoffs, like when the respiratory rate is above fill in the blank magic number 35, we shall intubate the patient. We like numbers because it makes us feel more comfortable with difficult decisions. The problem is this. Respiratory rate does not necessarily tell you that much about their work of breathing. Why? Well, it turns out that the mechanisms that drive higher respiratory rates aren't necessarily all having to do with how hard the patient is working to breathe. Because you have all these receptors, irritant receptors, stretch receptors in your lungs. And when they sense some inflammation, when they sense some excess stretch, as happens, say, for example, when you have a viral pneumonia, what they will do is they will directly tell the respiratory centers of the brain to breathe faster in a way that has nothing to do with how hard a patient is working to breathe. And so for me, the respiratory rate has become one metric, a useful metric, but not the only metric. And in fact, I am putting much less weight on the respiratory rate now than I used to. The trend of that number helps me, but again, I am just not paying nearly as much attention to that number as I used to. I am paying quite a bit more attention to accessory muscle use. We'll talk about why I think that's so very important in a moment. But a often forgotten, but actually keeping it really, really, really simple thing to assess a patient's work of breathing is getting pretty old school and simply asking the patient. Let's all not forget about that. Because I think that we're so busy devising scores and numbers and this, that, and this. We now have the COVID score, whatever it is, that, sometimes we forget the old-fashioned way of simply asking the patient. And so one of the things that I've started doing when I'm going around assessing my non-intubated COVID patients is just sort of doing a pain scale of 1 to 10, except it's a breathing scale, and being like, look, on a scale of 1 to 10, how hard is it for you to breathe? How much are you working to breathe? Do you feel like you're running a marathon or taking a nice stroll in terms of your breathing? So let's not forget to do that. Sometimes I'll even just trend the numbers because it makes us feel better to have numbers to trend. But do not forget about simply asking the patient. I have found this to be a very meaningful piece of information in a lot of patients. But by far, the most important number, the most important assessment, I should say, in terms of me making the decision about work of breathing in a COVID patient is accessory muscle use. Because when I'm trying to assess, should I be breathing? Should I be intubating this patient? Should I be intubating this COVID patient just based on their work of breathing? Or I have 2 COVID patients. They both have a O2 sat that sucks, like 85. But, should that determine that I intubate both of them? Or how much should it sway me that one of them, their work of breathing is terrible, one of them, their work of breathing is great? What does this mean? How much weight am I putting on this assessment? Well, I think the amount of weight I am putting on that assessment is all about their accessory muscle use, not about their respiratory rate, but about their accessory muscle use. And that is what has become really meaningful to me in terms of determining, is work of breathing a problem? As in, is increased work of breathing a problem such that it should cause me to intubate a patient? And the question here is, increased work of breathing a problem really has to do with getting back to goal number 2 of intubating a patient with a lung problem, which is preventing self-inflicted lung injury. So here's the idea. When you're breathing, you have these transpulmonary pressure swings. You inhale, your diaphragm goes down, and it creates a negative pressure in your chest, and that is what expands your lungs, and that creates a pressure swing, right? Now, depending on how much work you have to do to expand your lungs, you may have a relatively small transpulmonary pressure swing, or you may have a really big transpulmonary pressure swing. And it turns out that these very large transpulmonary pressure swings can cause something called self-inflicted lung injury. Now, when I first read about this a couple of years ago, I was like, wait, seriously? Like, really, is that a thing? Turns out it's complicated, and the data here is a little bit mixed, but there is a reasonable amount of interesting data that these high transpulmonary pressure swings, and note I say not volume swings, but pressure swings in this case, can cause self-inflicted lung injury. Now, there's some important nuance that goes on here, because you can have lots of people with perfectly healthy lungs and good lung compliance taking nice, big, deep breaths, and not necessarily causing themselves any lung injury at all. It's really, though, more about probably what large transpulmonary pressure swings are doing, and especially what they're doing to sick lungs. So let's go back to one of the previous lectures on Vents 101. And we talked about the relationship between volume and pressure in the lungs. And we talked about if you want to blow up your lungs, or in this case, you want to take a structure that has good lung compliance, like a beach ball. So we have nice, good, healthy, compliant lungs like our beach ball, and compare it to sick lungs, to basketball lungs, to sick, poorly compliant lungs. What's going to happen? So we have our healthy beach ball lungs, and then we have our sick basketball lungs. So if we look at what happens with these two different sets of lungs, well, it's kind of interesting when we start thinking about it in the context of self-inflicted lung injury. Because as I said, it's not somebody taking a bunch of deep breaths and taking big tidal volumes that's probably causing this. I mean, if just, like deep breathing exercises was causing lung injury, then, all those yoga classes probably wouldn't be so popular. That's not really it. It's all about whether your lungs are sick and what their compliance is, which is to say, it's probably all about these transpulmonary pressure swings. Why? Well, here's the deal. So the difference between healthy lungs with good compliance and sick lungs with poor compliance is that if you have the same tidal volume, if you put the same volume, let's say 300, in both your healthy, good compliance lungs and your sick, poor compliance lungs, what you will find is that the amount of pressure in those poorly compliant basketball lungs is much higher than the amount of pressure in your healthy lungs that have good compliance. And so, to get a tidal volume, the same tidal volume, in healthy lungs versus sick lungs, well, the sick lungs will need a higher pressure, higher transpulmonary pressure swings to get that same tidal volume. And these higher large pulmonary pressure swings, if you have a normal, nicely compliant lungs, you can have a relatively small transpulmonary pressure swing to get you a tidal volume that's reasonable. But in sick, non-compliant lungs that are getting sicker, then these large transpulmonary pressure swings seem to do a lot of damage. And this is one of the very important reasons that I am much more interested in the accessory muscle use than the respiratory rate. Why? Because the respiratory rate is all about high frequency. You're You're breathing fast, high frequency, but am I really concerned that breathing at a high frequency is necessarily causing self-inflicted lung injury? Not really, not necessarily. What am I more concerned about? Well, I'm concerned about those transpulmonary pressure swings causing self-inflicted lung injury. And those high transpulmonary pressure swings, they don't give you high frequency, they give you a high amplitude. Now, can I actually measure these transpulmonary pressure swings? No. I mean, I could theoretically if I really wanted to. Like if you really want to do this study, and in fact, that's how a lot of these studies have been done, you can put in a esophageal balloon and you can actually measure a patient's transpulmonary pressure swings. However, I imagine that if I went to the charge nurse of our step-down unit that is full of COVID patients on high-flow nasal cannula and face mask who are all citing 85%, and I was like, hey, so, I know we're running out of oxygen, I know we're running out of ventilators, and, I know we're running out of high flow, but you know what let's do? Let's put esophageal balloons in all these patients. They'd be like, yeah, no. So clearly, that is not something we're going to be doing for all of our patients right now, obviously, right? However, I think that if you're thinking about the amount of pressure it takes to get a given volume, reflecting the degree of your transpulmonary pressure swings, this is when you start to realize how important your accessory muscle use is. Because to me, increasingly, it is the accessory muscle use that is what's really reflecting the degree of these transpulmonary pressure swings. And so what do I mean when I say accessory muscle use? There's a really great article talking about this from quite a while by Dr. Tobin. That's fantastic. But the bottom line is this. I have started spending quite a bit of time staring very closely at my patients' necks and upper shoulders. And I literally the other night went around to our step-down unit because our ICU now, at least as of last night, there was not a single patient in our entire ICU who was not intubated. And so our step-down unit has basically turned into an ICU for all of the non-intubated COVID patients. So I just rounded on the step-down last night. And I'm pretty sure that most of the nurses and certainly all of the patients thought I was crazy because this crazy person comes in at like 1 a.m. and sort of sneaks in with a flashlight and is like, ma'am, I'm sorry, I'm just going to stare at your neck for a while, okay? So yeah, I'm sure all the patients think I'm an insane person. But what am I looking for? Well, I am really looking for their neck muscles, their upper chest muscles, and, their shoulder muscles. How hard are they working? Because if you just sit and you watch a normal adult breathing, their chest is rising and falling. Sometimes their belly will be rising and falling, but they should not be using the neck muscles of their lateral neck, their anterior neck, or their upper shoulders. They should not be using those muscles. And those muscles have become very, very important to me. And that is when I start getting very concerned about the patient, because I am beginning to become very concerned that if I start seeing this kind of accessory muscle use in my patients, forget the respiratory rate. You can have a rate of 35, 40. We've seen patients with COVID that have super high respiratory rates and they're hypoxic, and they're the ones who are sitting there chatting on their cell phones and eating flaming hot Cheetos, and they're like, oh yeah, my respiratory rate's 35 and my SAT's 75, but I'm kind of feeling okay. Those aren't the patients I'm talking about. When I'm looking at a patient, and I almost don't care so much what their O2 sat is, and I don't even care so much what their respiratory rate is, if I'm looking at them and they're having significant accessory muscle use, I am now getting very, very, very worried, because that is when I think that their work of breathing is beginning to be a problem. Why? Well, one, I'm worried that their work of breathing is beginning to become a problem because Are they damaging their lungs, right? Are they now having such large transpulmonary pressure swings that they're actually causing some self-inflicted lung injury? But two, I'm worried about the following. I've seen this now a number of times, so many times. I'm worried that my patients having increased work of breathing is the sign that should be tipping me off that they are about to fall off that cliff. I think for a lot of COVID patients, it's really tricky because we see some COVID patients where they start out satting 85 and they just hang out sort of satting 85 throughout their hospital course, and then they do fine and then they go home. On the other hand, we also see plenty of COVID patients that start out satting 85 and then they fall off this cliff. And this is one of the things we were observing initially in the COVID pandemic when we thought we were like, we got to intubate everybody right away because, they decompensate really, really quickly. And what I have found is almost every time that I have made a mistake, and there's been a lot of them that I've made in terms of intubating a patient too late, where there's patients that I was like, I waited too long. I should have intubated that patient. I have more or less yet to feel like I've made a mistake in a patient just because of hypoxia. In a patient where I'm like, I'm looking at you and you're awake, you're alert, you're talking to me, your work of breathing is fine, and your sats are freaking me out, but you have no accessory muscle use, no increased work of breathing. I feel like I haven't made very many mistakes in waiting for those patients. I'll wait and wait and wait, and it makes me nervous. The nurses are nervous because of their O2 sat, but I don't feel like that's where I've made mistakes. I feel like the mistakes I've made have been in the reverse direction. I feel like the big mistakes I've made in terms of waiting too long to intubate a COVID patient and having just a crash intubation where the sats are now 65 and I can't get them up and it's a mess. I feel like those mistakes I've made when I've been deceived by their oxygen saturation, actually, when I've been looking at a patient and been like, your work of breathing, it doesn't look good to me, but your sat's getting better. Your oxygenation saturation's actually way less bad than everybody else in the unit right now. That's when I've made mistakes. And sometimes, and I don't have data for this, but sometimes I'm beginning to wonder if, in some of these patients, it's really deceptive because maybe their sat actually gets a little better because they start working so hard to breathe that maybe their sat even transiently improves. But I am beginning to feel like that is often the thing that tips me off that this patient is about to fall off this cliff, is their work of breathing. And so that's why I've become very, very, very sensitized to the idea of accessory muscle use far over respiratory rate, and that really tipping me off. Now, unfortunately, I don't really have a score or can quantify accessory muscle use in the same way. And we like numbers, right? And one of the numbers I get asked about a lot with regard to work of breathing is, well, can we just use the CO2 as a magic number for telling us whether their work of breathing is bad and we should just intubate them because they're going to tire out? So again, I wish that I could tell you that this was a magic number that you could just use, and when their CO2 is more than, 40, ta-da, now you should intubate the patient. Unfortunately, yet again, I have no magic numbers for you. And there's two issues with this. The first issue is that, one, a normal CO2, what a normal CO2 should be, kind of depends on, how fast and how much they're breathing, right? If I'm sitting here and I'm breathing at a rate of 45 and taking big tidal volumes, if I'm breathing at 45, my CO2 shouldn't be 40, it should be 12. So if your patient is breathing at 45 and they have a CO2 of 45, that's not normal. If they're breathing real fast, their CO2 shouldn't be normal, it should be pretty low. And in fact, this is what we're seeing in a lot of the COVID patients, that initially they come in, and if anything, they have a respiratory alkalosis, because their respiratory rate will be really high. But it turns out that that's actually, unfortunately, not the only problem with using the CO2 in COVID to tell you when your patient is tiring out. Problem number two has to do with the issue of ventilation perfusion matching. So to remember the concept of VQ matching, because it turns out it actually is becoming very important to understand this concept when taking care of COVID patients in general. Let's review. So, VQ matching. In order for your lungs to match the amount of blood that goes to the places that are getting the most ventilation, that's your lungs' job, you need to have both an intact functioning alveolus and an intact functioning pulmonary capillary. Now, things going wrong with either of these two pieces can cause you to have VQ matching difficulties or ventilation perfusion mismatch, right? So, situation number one is that you can have a pulmonary capillary that's working fine, but you have some kind of problem with your alveoli. And in that case, you cannot get the oxygen in, and that is called a shunt. On the other hand, we can have the problem that our alveolus is working great, but now something is happening where our pulmonary capillary is not working. And that is a problem of getting the CO2 out, and that is called dead space ventilation, or specifically physiologic dead space. Now, you can have all kinds of problems along this spectrum. And what we are learning about COVID is that COVID is probably a disease that affects the pulmonary vasculature very significantly. That VQ mismatch is probably a central fixture of at least early COVID. Now, why do we care about this? Well, here's the problem. And this is the problem that I am, one, running up against in intubated patients with COVID, and two, makes it a little bit more complicated to figure out what the CO2 means in a COVID patient is the following. And it has to do with CO2 handling and physiologic dead space. Here is the deal. Increasing the minute ventilation does not fix physiologic dead space. So, what do I mean by that? Well, your minute ventilation is determined by your respiratory rate and tidal volume, right? And so the amount of air going in and out per unit time, that's your minute ventilation. So the faster you breathe with the bigger tidal volumes, well, that gets the CO2 out, right? Now, under normal circumstances, on a normal day, you breathe faster with deeper breaths and you get more CO2 clearance. So if your CO2 is high on your ABG, you breathe more, you breathe faster, your CO2 goes down. Wonderful. Now here's the problem. What if we have a bunch of physiologic dead space? What if we have some problem with the pulmonary capillaries so that they cannot get the CO2 to the alveoli? Well, what's going to happen then? Well, you can go crazy increasing your respiratory rate and tidal volume and moving a ton of air in and out of the alveoli, but it won't matter. Because, if you start with a CO2 of 65 and you're breathing, moving lots of air in and out of the alveoli, but the CO2 can't get to the alveoli, you won't have done very much for your PaCO2. So when you check an ABG, your CO2 is not going to have gone down by that much because of your physiologic dead space. So increasing the minute ventilation does not fix your physiologic dead space. Now, this is a particular issue when you contrast it with what happens with your end-tidal CO2 gradient. So we all like to measure end-tidal CO2. It's very useful. Sometimes we measure it at the end of intubation. I'll sometimes put it on a patient when I'm worried about their respiratory status if they're spontaneously breathing. But here's the deal. It turns out that this is an extremely interesting number to look at with COVID. Why? Well, think about it. So let's say you have some condition where you have a lot of physiologic dead space. There's some problem with the pulmonary vasculature, with the pulmonary capillaries, so that you can't get the CO2 out. So if you have this problem and you measure the arterial CO2 content, it's going to be high, right? Because you can't get the CO2 out of the blood into the alveoli to blow it off, so your PaCO2 is going to be high. But is your end-tidal CO2 going to be high? No, it's not. Why? Well, the whole problem is that you can't get the CO2 to the alveoli in the first place. And so, in fact, your end-tidal CO2 may be low. because you're not getting the CO2 to the alveoli anyways. And breathing in and out a lot, increasing your minute ventilation, will drop your end-tidal CO2. Moving all that air, yeah, you'll bring down your end-tidal CO2, but it won't do a lot to your arterial CO2. Now, if you have a situation where you get an ABG back and the CO2 on your ABG is high, but the CO2 on your end-tidal CO2 is low, that is called an end-tidal CO2 gradient. And if you see that, what that often means is that you have a lot of physiologic dead space. Now, why is this a problem when we are trying to use CO2 in COVID patients? Well, it gets a little complicated because what we are learning about COVID is that CO2 is a problem. We are learning that COVID has a lot of very significant effects on the pulmonary vasculature, on the pulmonary capillaries, that there is very, very, very profound VQ matching problems in COVID. And so because of that, because we have so much physiologic dead space in COVID, what that probably means is that your patient breathing harder and faster doesn't necessarily always have the effect on the CO2 on your ABG that you might think it would. And it means that your end-tidal CO2 may be deceptive. So in COVID patients, it's possible that your arterial CO2 may be deceptively high, your end-tidal CO2 may be deceptively low. As such, I find it really hard to know what this number means in COVID. Now, that being said, if I see a trend whereby either of those numbers is going up, I am concerned, because either that means that the patient is doing not as well with their minute ventilation, or it means maybe that their disease is getting worse. At the same time, since we just talked about the fact that, self-induced lung injury is caused when the patients are getting progressively higher and higher transpulmonary pressure swings, if they're getting worse like that, maybe they're even taking high tidal volumes, maybe their CO2 gets better. I just don't know. So I think this could be a very complicated number in COVID to interpret. And so, yet again, I don't have a magic number for you to assess work of breathing with. So, to sum up, when to intubate the COVID patient? Well, I'm basing this on two things. Hypoxemia, yes, to a point, but increasingly, I think that I have gotten, my tendency has gone in the following direction. I have become much less likely to intubate patients who are just hypoxemic. If their oxygen saturation is bad, like in the 70s, or they'll drop sometimes even lower, if their work of breathing is lovely, they're not using accessory muscles, they're not subjectively short of breath, and they're totally comfortable, I've become really insensitive, honestly, to their degree of hypoxemia. Now, that is not true if it's a patient who's altered, who keeps tearing off their O2 mask. I'm not happy if the patient's altered. So hypoxemia plus altered freaks me out. I'll intubate those patients a little bit earlier. But if they're just hypoxemic, that I've become pretty insensitive to. But what I've actually started doing is patients who have significantly increased work of breathing, I've actually started intubating them earlier than I was in the pandemic. I've actually, for the patients with really bad work of breathing, personally, if they have bad work of breathing, even if their oxygen saturation isn't awful, I mean, it's not going to be normal, but, it'll be often sometimes better than a number of the other patients, like if their SATs are at 90, 92, 93, but their work of breathing is awful, and I don't have some other cause for it, like volume overload or COPD or pneumonia or something, if I don't have another cause for them having significantly increased work of breathing, and I think that's really in the context of COVID is the main driver of their increased accessory muscle use, increased work of breathing, I've honestly started intubating those patients earlier and becoming less sensitive to their O2 sat. And so, I can't give you a magic number that'll tell you when to intubate them based on either hypoxemia or work of breathing. Really, I think that all we can do is be thoughtful and realize that there's not a magic number, and that what we're really doing is saying we accept the fact that it's not that simple, and instead we're just balancing lesser evils. We're balancing in this patient, in this hospital system, what is the lesser evil? Is the lesser evil hypoxemia or intubation? And then another lesser evil, which is balancing self-inflicted lung injury versus ventilator-inflicted lung injury. Their work of breathing is really bad. I'm concerned they're going to give themselves self-inflicted lung injury, but can I actually take care of them on a vent? Do I even have ventilators? Do I have intensivists who know what to do with the ventilators? It's a balance. And so, I think this is really hard. And I feel like at the end of this whole lecture, at the end of an hour, what I can still say to you is that I don't really know the answer. I don't feel like I have developed a clear formula. I don't feel like I've developed a clear, when you do this, and then A and flowchart and go to C. I still feel like I don't really know. But I do feel like trying to balance many different things. And for me, again, becoming very focused on work of breathing over hypoxemia. Can I tell you that's the definitive right thing to do? No, I can't, and I don't know. But hopefully, it's at least food for thought as we are all trying to deal with this very difficult and wrenching and important decision. So hopefully, at least, it gives you something to think about.